Good morning, and I wish you a nice and healthy week. Um, I hope you have relaxed during the weekend and you had the opportunity to meet your friends and your family and to spend some nice moments with them. I'm going to present you two books of our research group which were published last year by Springer Nature. I'm going to share my screen and present the books via a PowerPoint presentation. So, um, this is our therapeutic manual about treatment-resistant schizophrenia by Springer Nature. And here are the table of contents of our book. We begin with an introduction. Then we present the recovery process in schizophrenia and treatment-resistant schizophrenia. Then we go to a chapter about treatment-resistant schizophrenia with all evidence-based um, data and treatments about TRS. Then we go to our Greek model, recovery treatment resistance ER, a new recovery oriented model to treat treatment resistant schizophrenia. And finally, we go to an epilogue in which we draw our conclusions and we have the opportunity to present some information about regarding feedback of our patients with this program. Um, this is our recovery. Treatment-resistant ER lasts about 190 sessions. We begin with the administration of a test before the treatment. Then we go to an introductory phase of 20 sessions. We make a restart with a psychotherapy, with a pharmacotherapy and psychotherapy. We try to build a therapeutic relationship and we offer a psychoeducation to patient and family. We discuss about all past negative experiences with treatments and we try to enhance the assertiveness towards the rights of the people. Then we go to the second phase, which lasts 160 sessions. We begin with the cognitive phase, in which cognitive behavior psychotherapy for schizophrenia in 30 sessions and cognitive-oriented therapy in 70 sessions are offered, and both of the therapies were developed by Dr. Aaron Beck and his colleagues. Then we go to a pause of 2 months and finally to the metacognitive phase in which group psychotherapy and rehabilitation are offered. We begin with the integrated psychological therapy with 50 sessions twice a week, and then we go on with the metacognitive training with 10 sessions twice a week. The integrated psychological therapy was developed by Professor Volker Roder, Hans-Dieter Brenner, and colleagues at the psychiatric unit of the University of Bern in Switzerland, and the metacognitive training was developed by Professor Stefan Moritz and his colleagues at the neuropsychological unit at the Medical Center of the University of Hamburg in Germany. Both of these groups are efficacious and well known. Then we go to the third phase with 8 sessions. This is our epilogue, in which we discuss about relapse prevention and recovery as a process. And finally, we have 2 monthly individual sessions as follow-ups. Then we administer the test after the therapy and 6 months after the therapy as a follow-up. We give the possibility of repeating the therapy in case of relapse. This is our treatment-resistant bipolar disorder manual, which was also published by Springer Nature last year. I would like to thank Springer Nature and especially Dr. Silvana Freiberg for this wonderful cooperation all these years. So we begin with an introduction, and we speak about the recovery in bipolar disorder and treatment-resistant bipolar disorder. Then we focus on treatment-resistant bipolar disorder with the latest updates regarding psychopathology, comorbidity, and therapy. Then we go to our recovery treatment-resistant bipolar disorder GR, a new recovery-oriented model for treatment-resistant bipolar disorder. And finally, we go to an epilogue in which we draw our conclusions and we present feedback of our patients. Our recovery treatment-resistant bipolar disorder TR lasts 140 sessions. We begin with the administration of the test. Then we go to an introductory phase of 20 sessions. We make a restart with pharmacotherapy. We try to build a therapeutic relationship, and we offer psychoeducation to patient and family. And finally, we try to enhance the assertiveness of the patients towards their own rights. Then we go to a second phase of 108 sessions. We begin with the cognitive phase, cognitive behavioral psychotherapy for bipolar disorder for 30 sessions according to Beck, and cognitive-oriented therapy for 70 sessions according to Beck. Then we go to a pause of 2 months, and finally we go to the metacognitive phase, in which group psychotherapy is being implemented, and especially metacognitive training for bipolar disorder, 8 sessions once a week. Then we go to the third phase, in which 8 sessions are going to be offered as epilogue. Relapse prevention and recovery as a process are the main issues. And finally, we have 4 monthly individual sessions as follow-ups. We administer tests after the therapy and 6 months after the therapy as a follow-up. We have the possibility of repeating the therapy in case of relapse, and we recommend cognitive behavioral couple therapy after our program. So the recovery perspective is a very important perspective in both of these therapeutic manuals. We have the objective recovery. This is the result of the test that we as mental health experts administered, self-test and clinician evaluation, also an evidence-based psychometric evaluation regarding psychopathology, quality of life, and functional outcome. Recovery as a process, or subjective recovery, is the point of view of the clients, the point of view of families of the clients. They learn to take responsibility towards their own problems and to participate on their own problems. They are the protagonists of their own life, and this is a dynamic procedure. So our programs have advantages and disadvantages. The disadvantages are that they are long-term treatments. This can be a disadvantage for some of the experts or the patients. Some patients don't want to participate on long-term treatments, and some experts are not able to offer long-term treatments. Another disadvantage in a short term can be the fact that both of the programs activate intensive grief reactions after psychoeducation or awareness. Well, in a short term, this can be a disadvantage, but in a long term, this can be an advantage. And finally, both of the programs have advantages. We offer psychoeducation, evidence-based pharmacotherapy, evidence-based psychotherapy, and rehabilitation. We avoid polypharmacy. It's very important today to avoid polypharmacy. We know that polypharmacy leads to many side effects or serious organic problems. Patients have the right to take only the appropriate medicines, and this is a human right. So our program offers a democratic context in which everything can be discussed, even if we disagree. Every difficult moment can be discussed with all the details and with all the possible solutions. Both of them are long-term treatments and they lead to recovery and resilience. This is a clinical trial that is going on right now. In this clinical trial, recovery treatment-resistant CR and recovery treatment-resistant bipolar disorder CR will be compared with a control group in a randomized control trial. I mean, recovery treatment-resistant CR with a control group and recovery treatment-resistant bipolar disorder CR with a control group. But we have implemented pilot groups with both of the groups, with both of the programs, and we have first positive results regarding the improvement of cognitive functions, psychopathology, recovery, and functional outcome. We have implemented a clinical trial between 2022 and 2024 in which we evaluated the effectiveness and efficacy of the combination of the pharmacotherapy, integrated psychological therapy, and metacognitive training. This was a non-randomized controlled trial, and this is the metacognitive phase of our recovery, treatment-resistant CR, of our new recovery-oriented model for treatment-resistant schizophrenia. So we have statistical significant results according to general linear model regarding cognition, functional outcome, recovery, and psychopathology for the whole sample, but also for the 32 people with treatment-resistant schizophrenia. And then we have conducted a regression analysis for the whole sample. Some of the results are, for example, that 54% of the problem solving, 44% of the negative symptoms, and 22% of the total recovery can be explained through this combination of treatments. And when we focus on the 32 people with treatment-resistant schizophrenia, and some of the results are, for example, 54% of the verbal memory, 41% of the negative symptoms, and 25% of the total recovery can be explained through the combination of these treatments. Our effect sizes are the following. We have a medium total therapy effect size of 0.72, a medium effect size for cognition and psychopathology, and large effect sizes for functional outcome and recovery. And when we focus only on the 32 people with treatment-resistant schizophrenia, we have a medium effect size of 0.41 as total therapy effect size, a small effect size for cognition, and medium effect sizes for psychopathology, functional outcome, and recovery. So our clinical trial have advantages and disadvantages. For example, The advantages is that this combination of treatments is being implemented for the first time internationally, and that um, uh, we try to improve many uh, categories, many variables regarding cognition, psychopathology, functional outcome, and recovery. And we have medium effect sizes as total therapy effect sizes. The disadvantages is that this is a not randomized controlled trial, so we have not a control group to compare the treatment. The sample is small. Um, but on the other side, this is the first time we try to combine pharmacotherapy, IPT, and MCT in such a difficult category of patients with schizophrenia, such as treatment-resistant schizophrenia. We need more empirical data regarding what works and what not by patients with treatment-resistant schizophrenia. So our non-randomized trial belongs to this category. And as I said, we have implemented pilot groups, and this is a letter which was written from a patient from the recovery treatment-resistant CR pilot group. And this is a very good example of recovery as a process. So I wanted to die by suicide for many years. I have gone to numerous mental health experts who have prescribed many medications. I slept all day, and the rest of the day I smoked and consumed a lot of junk food. I was very desperate with respect to my life and daily routine, attempting to find a job without success. A friend of mine who suffers from TRS has referred me to the experts. I met them in 3 sessions to arrange to clarify how this program can help me. I decided to start with this therapy. I have learned what the issues of TRS are, why I took so numerous medications from past psychiatrists, why clozapine helped me, and how the absence of side effects of pharmacotherapy progressed my quality of life. Psychotherapy had shown me techniques to manage anxiety, depression, lack of motivation, coping with delusions and hallucinations. I'm very happy when I accomplish little objectives. I made follow-up sessions with the experts. I have moved forward my relationship with my family. And this is a letter from a patient of the pilot group of recovery treatment-resistant bipolar disorder, TR, also a very good example of recovery as a process. I wanted to die by suicide for many years. I have gone to numerous mental health experts who have prescribed many medications. I slept all day. I was very desperate regarding my life and daily routine, attempting to find a job without success. A friend of mine who suffers from TRS bipolar disorder has referred me to the experts. I met them in 5 sessions to arrange to clarify how this program can help me. I decided to start with this therapy. I have learned the problems of treatment-resistant bipolar disorder, why I took so numerous medications from past psychiatrists, and why clozapine and lithium helped me. I suffer from treatment-resistant bipolar disorder, and the balance regarding my pharmacotherapy depends on my compliance. I take my agents every day because I know why. Cognitive behavioral psychotherapy and metacognitive training had helped me manage my anxiety, my depression, and my hallucinations. I recognize my depressive and manic phases, and I contact with the experts if something changes for me. I control my psychopathology better. I have improved my relationship with my family. We spend a lot of time together without verbal abuse. I'm not the bipolar disorder, this is my disorder, so they have to respect that. I fight every day against treatment resistant bipolar disorder. There's always a way to manage the negative consequences of a mental health disorder, and that's what I have learned with this program. The recovery perspective in treatment-resistant schizophrenia and bipolar disorder is a main issue in our programs. We offer evidence-based psychotherapy and rehabilitation, and pharmacotherapy, recovery as an outcome before, after the therapy, and in follow-up, and recovery as a process before, after the therapy, and in a follow-up are very important. This is a dynamic context because long-term evidence-based therapies in the context of CBT and rehabilitation are combined with each other. And this is a real democratic context because we spend a lot of time together and we have a lot of time to discuss many things. We would like to thank all our patients who participated in our programs and who participate right now in our programs. And we would like to dedicate our programs to these people and especially to those who cannot have an access to evidence-based psychotherapy. This was small presentation of our books. So why we have cooperated with each other many years, and we have discussed a lot of hours about the difficulty of treatment resistance in mental health disorders. So treatment resistance in mental health is about 20 to 60%. So 20 to 60% of the mental health disorders are treatment resistant. It's a huge percentage, and that was one reason do we why we decided to develop specialized treatments for treatment-resistant schizophrenia and treatment-resistant bipolar disorder. The second reason was the fact that these people are highly suicidal, they are very isolated, and they lose trust to the experts. They don't have a good compliance to pharmacotherapy and psychotherapy. They have a high percentage of cognitive dysfunctions, which make their lives more difficult. When you have cognitive dysfunctions, you're not able to be functional, to interact with other people, to work functionally, and to interact socially with other people. We're very proud of these therapies. We implement them right now in our private practice, and an ongoing research protocol is a reality. So people have the opportunity to participate on our research protocol and to have a long-term therapy. Another reason why we develop these therapies is that we had about many stories from our patients regarding the abuse with which they are confronted regarding pharmacotherapy and psychotherapy. For example, through polypharmacy or through psychotherapy, therapy which is not evidence-based for these categories of patients, or psychotherapy from experts who are not well experienced with these disorders. We have discussed many years about all these problems, and we are always for action. We prefer to be activated, to act and not only to discuss theoretically. So the result of this action was these two books. So I hope you will have the opportunity to read our books, and if you are interested in our therapies, even if you are patients with treatment-resistant schizophrenia and bipolar disorder, or even if you are experts, you can contact us, and we can discuss any possibilities for implemented those therapies. So I wish you all the best and take care.